Hi guys, good evening. Welcome back. Hi guys, good evening, good evening. So, we're talking about the component of the thyroid that we left out on the last week. तो इस week का जो motive है, that is to complete our entire thyroid. तो 3 topics बचे हैं. One is going to be your inflammatory thyroid swellings, which we'll be discussing today. Tomorrow will be cancers, and Wednesday will be a showdown with the thyroid surgeries, intraoperative surgery. We'll show you every single step of the thyroid surgeries, how to do it, what not to do it, how do you manage post-operative complications. Dark Shadow, Sohil, good evening guys, good evening. Hi Osama, good evening. Hi Mansoor, good evening. Hi Rahul. Chalo. ठीक है, can we start? करें शुरू. So we're talking about one of a very important topic that we have. It is going to be the inflammatory thyroid swellings. So today's objective to talk about the inflammatory thyroid swelling, right? Now in the inflammatory thyroid swellings, we'll be discussing about 3 important swellings that we'll be talking about. One, we'll talk about the Hashimoto's thyroiditis. We're talking about Hashimoto's, we'll be talking about Quervain's, and we'll be talking about Riedel's thyroiditis. So 3 settings or 3 swellings that we'll be discussing here. We'll be talking about the Hashimoto's. We'll talk about the Hashimoto's thyroiditis. We'll talk about the Hashimoto's thyroiditis. We'll talk about the Quervain's thyroiditis. And we'll be talking about the Riedel's thyroiditis. Now, before we move down, as the word itis, right? Itis basically means inflammation, right? So when you talk about inflammation, we have 3 different types of inflammation. You have acute, you have subacute, and the chronic forms of inflammation. Can anybody tell me Hashimoto's is which type of inflammation? Hashimoto's is which type of inflammation? Is it an acute, is it a subacute, or a chronic form of inflammation? Remember, Hashimoto's is an example of a chronic inflammation. It is an example of a chronic inflammation. When you talk about the Quervain's thyroiditis, Quervain's is an example of a subacute inflammation. This is an example of a subacute inflammation. And Riedel's thyroiditis is again an example of chronic inflammation. So the 3 forms of disorders that we have, and all these 3 have their own subsets and their own features and their own criteria. But for you need to remember that 3 variants of the thyroid swellings, that is in terms of inflammation, is going to be Hashimoto's is chronic, Quervain's is subacute, Riedel's is another example of chronic thyroiditis, right? So we're talking about each individual component. We'll start with the first and the foremost. That is going to be the Hashimoto's thyroiditis. So we're talking about the Hashimoto's thyroiditis. Now, as we know, it is an inflammatory disorder. There has to be a reason for inflammation, right? So is it a known or an unknown reason? Hashimoto's is quite known reason of the inflammation, right? So what is the cause for Hashimoto's thyroiditis? Any idea? What is the cause for the Hashimoto's thyroiditis? The cause for the Hashimoto's thyroiditis, it is an autoimmune disorder. This is an example of an autoimmune disorder. So whenever we say it is an autoimmune disorder, it will be associated with the antibody. Can anybody tell me what is the antibody that is associated with the Hashimoto's thyroiditis? A quick feedback. What antibody do you think? Osama, you are correct. It is an autoimmune disorder. What is the antibody that is going to be associated with Hashimoto's thyroiditis? Quick feedback. Okay, so it is your anti-thyroperoxidase, that is anti-TPO antibody. It is going to be the anti-TPO antibody. Rahul, you are absolutely correct. It is an anti-TPO antibody. So what is the whole story behind? Like, now these antibodies, let's say this is the thyroid follicle. We know within the thyroid follicle you have these enzymes which are called as the thyroperoxidase enzymes, and these thyroperoxidase enzymes are responsible for every single reaction that occurs in the thyroid follicle for synthesis of T3 T4, that we have already understood, right? So this that you have depicted here, I would say this is your thyroperoxidase enzyme. So this is a TPO that is present, right? So these anti-TPO antibodies which are formed, these are your anti-TPO antibodies. So these are synthesized. Now these antibodies has only one target, that they want to go and kill the thyroperoxidase enzyme. So they are born to kill. Their only, single motive in life is to go and kill these thyroperoxidase enzymes, right? So all these antibodies which are synthesized, these antibodies has only one role, that these antibodies will go and they will kill the thyroperoxidase enzymes. So one fine day, they all walk towards it. They say, okay, let's go to the thyroid follicle and we are going to kill the thyroperoxidase enzyme. So all these antibodies reach to the thyroid follicle, they knock at the thyroid follicle's door, knock, 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 knock. Can you please send the TPO outside? Follicle says, get lost. If I give you TPO, what will I do? Every single thing that occurs inside the thyroid follicle is catalyzed by thyroperoxidase enzyme. I will not give you TPO enzymes. Go do whatever you want. Get lost, is what your thyroid follicle says. But these antibodies are so determined. They say, no, we will take these, thyroperoxidase enzymes. Without thyroperoxidase enzymes, I'm not going to leave. I want to kill those thyroperoxidase enzymes. But you know what? Thyroid follicles are so strong, they will not allow these antibodies to enter and kill. So what is going to happen? These antibodies, they have a round conference, they think about it, what to do, and suddenly they say, okay, fine. If I cannot kill somebody, how do I do? I'll go hire an assassin. And who is that assassin? So all these antibodies, they go to the best, the supari guy in town, that is your CD4 cells. They go and talk to the CD4 cells and they say, CD4, there is a problem. We want to kill the thyroperoxidase enzyme, but the follicle is not allowing us. CD4 cells say, chill, relax, don't worry. We have the best assassin in town. And who is that best assassin in town? That best assassin in town is your cytotoxic T cell, that is your CD8 cells. So they go and activate the CD8 cells, which are cytotoxic. These are your cytotoxic T cells. So CD8 cells are going to get activated. The problem with CD8 cells is they don't like talking. These are the guys who would be like, cool, we have a task in hand. I'm not going to go chit chat. So these CD8 cells go to the thyroid follicles, and before thyroid follicle could explain the problem, they just knock the follicle out and they disrupt the follicle. They go hit the follicle so hard, the follicle is now kaboom. It is blasted, it is destroyed. Now, as the follicle is destroyed, you will notice that all these thyroperoxidase enzymes are going to release out. So all the thyroperoxidase enzymes which are present inside the follicles, now they're going to be released out. Now, as the thyroperoxidase enzymes are released out, all these antibodies which are present, now these antibodies will now go to these sites and they are going to bind to these thyroperoxidase enzymes and they are going to engulf. So their revenge is completed, right? So I hope you understood how they were able to achieve their revenge. I'll repeat again. These antibodies which are formed, they go to the thyroid follicles, they knock the thyroid follicles to give the thyroperoxidase enzymes outside. Follicle says, get lost, I will not give you TPO. If I give you TPO, what will I do? So hence they go and talk to CD4 cells. CD4 cells, okay, fine, I'll send CD8 T cells. CD8 cells, they don't talk to the follicles, they go and knock the follicles out. Follicle gets disrupted. All the thyroperoxidase enzymes are released. These antibodies goes and engulf. Their job is done. But what is the problem? The problem is, what will happen to this poor follicle? Now this poor follicle which has been ruptured, now this is the sorry state of the follicle. The follicle has been broken down. So this is how the follicle has been ruptured. It is lost. Now as the follicles is ruptured, we know there's a lot of reserve that was present. No, all the T3, T4 which is present in the reserve, what is going to happen? There will be a sudden release of T3, T4. That sudden release of T3, T4 because of the rupture of the follicle will cause sudden rise. there'll be a sudden increase in T3, T4 circulation. So this sudden increase or sudden release of T3, T4 into the circulation will result in hyperthyroid status. So there'll be a transient hyperthyroid phase, but eventually what is going to happen? Eventually this follicle which is ruptured, eventually it is now going to go and get fibrosed. So this follicle is going to die off. Now, as eventually all these follicles are now going to get withered off. All these follicles are now going to go withered off. This is how it is going to become lost. So the follicle is fibrosed. Now, if the follicle is fibrosed, what is going to happen, right? Now, you have to understand it this way. If the follicles are fibrosed, you need to understand, if you take this as the representation of our thyroid gland. Let's say this is the normal representation of the thyroid gland. Just for the sake of understanding, I'm going to draw these follicles. Let's say this is the follicle that are present, right? So these are the set of the follicles which are present, and few of the follicles are ruptured and fibrosed. So let's say this is the follicle that is ruptured and this is going to get fibrosed, right? So whenever there is the follicle ruptures, when it just gives away, what is going to happen? This follicle which is ruptured will get fibrosed. But what is going to happen? The surrounding follicles which are left behind, they have to compensate, because follicles are lost, the T3, T4 production will fall. In order to compensate that, what is going to happen? The leftover follicles, they are now undergoing hypertrophy. Now, as they undergo hypertrophy, it's a compensation hypertrophy that they take place in order for the lost follicles. Now, because whichever follicles are left behind, they are now undergoing a compensatory enlargement or hypertrophies. Because of this, the gland will also slowly start to enlarge. Now, this enlargement of the gland is because of the hypertrophy of the follicles which were left behind. The follicles which are damaged, they are damaged. Whichever follicles which are left behind, in order to compensate. So these are the damaged follicles we're talking about. So there are follicles which are damaged here. So whichever follicles are left behind, to compensate for the leftover, the other follicles are going to enlarge in size. Now, as they enlarge, the gland is going to enlarge. Eventually, you will notice that these episodes are going to occur repeatedly. Now, as these episodes are going to occur repeatedly, the gland will continue to enlarge, and this enlargement of the gland is because of the compensatory hypertrophy of the leftover follicles. So this is the leftover follicle that you can see. Whichever follicle is left behind, it will continue to hypertrophize. So that it can manage the secretions of the T3, T4. So what is going to happen? The follicles which are getting fibrosed. So these are the fibrosed follicles that you can see. So whenever the follicles are getting damaged, those follicles are getting fibrosed. The leftover follicles, they undergo hypertrophy, and that hypertrophy of the follicles will result in the gland enlargement. So you now know in Hashimoto's thyroiditis, this is normal, and from here you can see the gland continues to enlarge. As more and more inflammation will occur, or more and more damage will occur, there will be more compensation. As there is more compensation, the gland will continue to enlarge, and patient will now present to you with signs and symptoms of thyroid swelling. So as more and more follicles will continue to destroy, obviously the concentration of follicles in the thyroid will decrease. As the concentration of the follicles will decrease, obviously T3, T4 production will decrease. So eventually all these patients, because more and more amount of follicles are going to get destroyed. As more and more amount of follicles are destroying, the leftover follicles continue to compensate, but they cannot compensate to a point where they can become normal. Now, because they cannot become normal, or they cannot have normal synthesis of T3, T4, eventually the patient will become hypothyroid. Okay? At the end, the story is very simple. There is damage, there is compensation, there is damage, there is compensation. It will compensate to a point. It will compensate to a point where it can synthesize equal amount of hormone, but there's a point where it cannot compensate further. No, because as more and more amount of follicles are destroying, as more and more amount of compensation is occurring, there's a point where it reaches, okay, enough, I cannot compensate any further. So at this point, you will now notice that the follicles which are enlarged are not able to produce enough amount of T3, T4. So eventually the patient will become hypothyroid in status. Did you all get this point? Right? So in Hashimoto's thyroiditis, there are two things that we have understood, right? What are the two things we have understood? The first thing we have understood that there will be damage of the follicles. Now, as there is damage of the follicles, it will cause excessive release of T3, T4. So there will be sudden increase in T3, T4 release, causing transient state of hyperthyroidism. But eventually, as the gland is getting destroyed or the follicles are getting destroyed, the gland continues to compensate, and that compensation will cause enlargement of the gland, yet will also result in hypothyroid status eventually. Hi Eka, thank you for watching. Okay, you're from Africa. Right, thank you. So this is the whole subset. I hope everybody is clear. Okay. Okay, so this is how. So this is how you can see the gland is going to compensate, right? Now, if you talk about what are the salient features of Hashimoto's thyroiditis. So the salient features of Hashimoto's thyroiditis, number one, it is an autoimmune disorder. It is an autoimmune disorder, as we have already spoken. It is associated with anti-thyroperoxidase antibody. It will be associated with anti-thyroperoxidase antibody. It is also associated with HLA. It is the HLA that it is associated is going to be HLA-B8, HLA-DR3. These two we have already heard in Graves' disease. One more you add is HLA-DR5. HLA-B8, HLA-DR3, HLA-DR5. This is usually your NEET PG question or the INICET. Usually in a competitive exam, they'll ask you questions like this, in which, see, antibody, they've asked you the name. You should know the name of the antibody. You should know what HLAs it is associated with. So these are in that particular context. Now, how would a patient present to you with respect to Hashimoto's thyroiditis, right? Majority of these patients, because it's an autoimmune disorder, as it is more common in females, you will see a young female, relatively young, I would say. You will see females are more commonly affected when compared to males, and the usual age of presentation is between 30 to 40 years. It is a chronic inflammation. That means repeated inflammations occur, repeated antibodies will be produced, repeated attack will occur, repeated inflammation, and repeated inflammation heals by fibrosis. So here there will be periglandular fibrosis as well. So what are the presentation would be like? So these are the patients who are going to present to you with number one, presence of midline neck swelling. They'll present to you with midline neck swelling. Now these midline neck swellings, they are going to remain painless. They're absolutely painless, and as we all know that this is going to move upwards with deglutination. So every time the patient swallows, the gland is going to move upwards, right? The gland is going to move upwards. It's a midline neck swelling. It remains painless. It is going to move upwards with deglutination. This is the initial presentation that you would see. Now, I would like to examine. So on examination, what do you find? On examination, you would see it will have a nodular surface because of the differential growth. We all know why there's a differential growth, because every time there is an attack, few follicles get destroyed, the other compensates. Again, few follicles destroyed, the other one compensates. Whichever compensates will become more larger in size. They will present to you as nodules, right? Rest of the gland is going to regress in size. So it will have a nodular surface. It will be hard because of the fibrosis. So when you palpate, you will have the hard consistency, right? It is nodular, it is hard, it is non-tender. This will be non-tender. So there is no tenderness when you palpate on this, right? Now, another thing that you will notice, these patients, eventually all of them will land up with signs and symptoms of hypothyroidism. So they will land up with signs and symptoms of hypothyroidism, right? So I now have a female who is between 30 to 40 years old, presents with the midline swelling of the neck. It remains painless. It moves upwards with deglutination. It moves upwards with deglutination. Just give me a second, guys. Sorry. Yeah, it moves upwards with deglutination. On examination, you have nodular surface, hard in consistency, non-tender when you palpate it, and there's signs and symptoms of hypothyroidism as well. How would you like to evaluate this patient? So when you have a patient like this, how would you like to investigate? We have already dealt enough amount of scenarios like this. Swelling in the midline of the neck, moves upwards with deglutination, remains painless with features of hypothyroidism. So what will you do? What are you going to do? The first thing, I will do a thyroid function test to confirm whether the patient is having hypo-U or hyperthyroid. In the thyroid function test, I'll be measuring T3 levels, I'll be measuring T4 levels, I'll be measuring TSH. Now, because the follicles are getting destroyed, now destruction of the follicles will cause decrease in T3, T4 production, and because of the negative feedback, it will cause increase in TSH. शुभम सिन्हा बंगाली नहीं आती है बेटा, हिंदी, इंग्लिश, तेलुगु, कन्नड़ा, ये मेरा स्पेक्ट्रम है, इसके बियॉन्ड नहीं. ठीक है, चलो. So T3, T4 false because the follicles are getting destroyed. Because of the negative feedback we've already discussed, that TSH is going to increase. Now, because I have a hypothyroid patient, I would like to evaluate the gland with the help of ultrasound as well as FNSC to look for any other compensation that is present. Okay? Now, you have a thyroid function test. You did an ultrasound. You know there's a nodularity of the gland. You did an FNSC. You ruled out the malignancy. And the last thing that you would like to do is to look for antibody titer. Look for an antibody titer. Okay? In the antibody titer, I will look for anti-thyroperoxidase antibody. I will look for anti-thyroperoxidase antibody. Right? Now, here on the FNSC, you will find the characteristic cells which your pathologists are going to be quite intriguing. शुभम सिन्हा कुछ समझ नहीं आ रहा. बेटा शुभम कौन से मेडिकल कॉलेज से हो? शुभम कौन से मेडिकल कॉलेज से हो यार? कोलकाता से? कहाँ से? स्पैम मत करो यार. If you spam, there is no point. If you're a doctor, behave like one. ठीक है? लिख ले बेटा. बता के थक गया हूं, नहीं समझ में आ रहा तो लिख ले, जितना लिखना लिख ले, कोई टेंशन नहीं. ठीक है? चलो. Now, why would you like to do an FNSC? Because you'll see a characteristic cells that are going to be present. Number one, you will see presence of Hurthle cell. There will be presence of Hurthle cells. Along with that, you will see the Ashkenazi cells. You will also see presence of Ashkenazi cells. Okay? These are the two cells. Very good. These are the two cells that are going to be present on an FNSC. So when you do an FNSC, you will find there is a Hurthle cell and they will see presence of Ashkenazi cells. Okay? Very good. Now, just for the sake of understanding, I'll give you another important point that Hurthle, that your Hashimoto's is also known as the Hashimoto's thyroiditis. Hashimoto's thyroiditis is also known as, it is also known as, if anybody knows, feel free to say it. It is called as the stroma lymphomatosum. It is the stroma lymphomatosum. It is also known as the stroma lymphomatosum. Right? So Hashimoto's thyroiditis is known as the stroma lymphomatosum. Okay? Now, once you have diagnosed, right, we'll give a quick recap of what has happened in the Hashimoto's thyroiditis. In Hashimoto's thyroiditis, we had a patient who have an antibodies named anti-thyroperoxidase antibodies, which are directed towards TPO. The follicle cells were guarding them, so they were not able to attack it. They went to CD4 cells, they activated CD8 cells, they destroyed the follicles, all the enzymes were released, that is TPO. Antibodies took care of it. But the excessive T3, T4 that is released due to the follicular rupture initially will result hyperthyroid status, but eventually, because the entire gland is getting fibrosed and replaced by the follicles into a fibrotic tissue, you will eventually become hypothyroid in status. Now, this is what we have been discussing in terms of presentation, that how it is going to look across. So you will have a patient who will have features of hypothyroidism eventually with the swelling in the midline of the neck. We worked it up. Now I got the diagnosis of Hashimoto's thyroiditis. Now, when you have a patient with Hashimoto's thyroiditis, how do you manage? Now, before you manage Hashimoto's thyroiditis, let me tell you what is the problem that I'm going to face as a surgeon. Now, let's say this is the representation of the neck. Let's say this happens to be the representation of the neck, and let's say this is the thyroid gland that we're talking about. This is the thyroid gland that we are talking about, right? So right next to the thyroid gland, from our anatomy knowledge, we know there is a common carotid which is going right across here. There's this internal jugular vein that is going right across here. Then you have the vagus nerve which is going to be accompanying this point as well. So this is the common carotid. You have the vagus nerve which is going to be present across here, and all this is encased in a fascia which is called as the carotid sheath, right? So carotid sheath is running right next to your thyroid gland. The problem is, whenever there is an inflammation, there'll be a lot of periglandular fibrosis, right? So all this inflammation will be around the gland, and because of that, there'll be a lot of inflammation which is called fibrosis. There'll be a periglandular fibrosis. Now, because of the periglandular fibrosis, you see the gland is going to get plastered to the surrounding area. So because of periglandular fibrosis, there is repeated inflammation will cause fibrosis. There'll be a lot of plastering. So one, it can plaster to the carotid sheath. Second, we know that the superior laryngeal nerve is going to come in this way, and the recurrent laryngeal nerve is going to come this way. And because this is also getting adherent, to that of the thyroid tissue, it becomes very difficult for me to dissect the plane and remove it. So while removing the thyroid gland, I can cause damage to the carotid sheath, I can cause damage to superior laryngeal nerve, I can cause damage to recurrent laryngeal nerve, hence causing chaos. So here, doing surgery is going to cause more harm than benefit. So for my patient, I would not like to operate. So management in Hashimoto's thyroiditis is going to be conservative. So in a conservative, what am I going to do? In a conservative line of management, I will start the patient on T4 supplementation, that is thyroxine, to counter the hypothyroid status. Right? The problem here is, as the gland continues to enlarge, if the gland becomes so big, it becomes huge, it is now going to exert pressure. So here, see, why I will not give carbimazole, beta. In hyperthyroid status, it is very unlikely the patient will come eventually, but it's a very transient phase. Eventually, they will present to us hypo only. Patient will say, yes, she had features of hyperthyroidism initially, but by the time the gland becomes large, patient presents to you, it is usually in hypothyroid status only. Correct? Now, Mansoor, you're absolutely correct. What if the patient with the gland becomes enlarged? It will present to you with severe symptoms. It is now going to present to you with severe symptoms, and these severe symptoms are pressure symptoms. These are going to be your pressure symptoms. Right? Now, once the patient starts developing severe pressure symptoms, what will you do? I cannot go and operate and remove the entire gland because it can cause more damage. So here's the important point. Remember, for such patients, the surgery of choice to relieve pressure symptoms, in an inoperable thyroid swelling, in an inoperable thyroid swelling, this is going to be isthmectomy. So in an isthmectomy, if you look at this, right in the center, it is the trachea which is getting compressed. Right? So I'll take the representation. This is the trachea. These are the tracheal rings that are present. This is the esophagus that is traveling behind it. So this is the esophagus that is going to be traveling behind the trachea. And then you have the vertebra which is going to be on the posterior most side. So rather than say, I'll say the posterior most side that you will see is going to be the vertebra. So this is the vertebra that you would see on the posterior most side. That is the vertebra that is present. This is the vertebra on the posterior surface that is going to be present. On the posterior surface that is present, and in between this you have the recurrent laryngeal nerve, which is the tracheo-esophageal groove. Now you see the gland which we are talking about, if it becomes quite large. So this is the thyroid gland. So here this is the isthmus of the thyroid gland, and this is the thyroid lobe that is present. So if you understand the whole dynamics of the pressure, the whole dynamics of the pressure is because of the thyroid gland exerting pressure onto the trachea. It is the thyroid gland that is exerting pressure onto the trachea as well as the underlying structures. But if you observe very carefully, it is not the entire thyroid gland that is exerting pressure. It is only this part of the thyroid gland. You see this bridge, this isthmus is compressing it because this is what it is sitting on the trachea. Right now you have a patient who's having a severe pressure symptoms. That pressure symptoms is because of isthmus exerting pressure on the trachea as well as on the esophagus as well as on the recurrent laryngeal nerve. What will you do? I cannot operate because, as I told you, there's a lot of periglandular fibrosis. So because of the inflammation, there's a lot of periglandular fibrosis. So if I go and try to remove the gland, I will only cause more damage. I will only cause more damage and more injury. So in order to overcome this, what am I going to do? I am simply going to go and remove the isthmus. And this surgery of removing the isthmus is what we call it as isthmectomy. So I have performed isthmectomy here. So once you perform isthmectomy, you are now removing the part which was causing pressure on the trachea. I have freed the trachea now. The trachea is absolutely free of the pressure that is exerted. You see the esophagus is also absolutely free of the pressure that was exerted on this, and the recurrent laryngeal nerve which is traveling is also free from the pressure. So if you remove the isthmus, because there is no fibrosis usually around the isthmus, it's easy for us to relieve. The lobes are separated, the trachea is freed, the patient will not feel any pressure, and this surgery is what we call it as the isthmectomy. So the surgery of choice to relieve pressure symptoms in an inoperable thyroid swelling is your isthmectomy. Clear? So if you talk what is the main line treatment of Hashimoto's thyroiditis, the answer is going to be, it is going to be T4, which is going to be supplementation with thyroxine. But if there's a severe pressure symptoms, I would have to go ahead with isthmectomy, right? So this is in terms of Hashimoto's thyroiditis. Now in the same way, we have another inflammatory thyroid swelling which is called as the D. Quervain's thyroiditis. So let's see what happens in D. Quervain thyroiditis. D. Quervain's thyroiditis is an example of a subacute thyroiditis. It is an example of a subacute thyroiditis. It is an example of subacute thyroiditis. So if you say, what is the cause behind this? The cause of the D. Quervain's thyroiditis, it is because of cross-reacting. It is because of cross-reacting antibody after upper respiratory tract infection. So after an upper respiratory tract infection, there develops a cross-reacting antibodies, and these cross-reacting antibodies are against the thyroid follicles. These antibodies which are synthesized, they are against, they are synthesized against the thyroid follicle. They are synthesized against the thyroid follicles, right? There's a cross-reacting antibodies. Now these cross-reacting antibodies, they are synthesized they are synthesized against the thyroid follicles. Now, if you take this as the representation, if you take this as the representation of the neck, sorry, if you take this as the representation of the neck, now we'll talk about in the same context. Let's say this is the trachea, which is going to be the upper respiratory tract we're talking about. So post upper respiratory tract infection, it is usually a viral infection. You see, this is the thyroid gland that we have present. This is the representation of the thyroid gland. Within thyroid gland, these are the thyroid follicles which are going to be present. These are the thyroid follicles which are going to be present. So what is going to happen? There will be a upper respiratory tract infection. Let's say there's this viral infection that has occurred in the upper respiratory tract. Now, for these viral infections, there will be these antibodies which are going to be synthesized. So these antibodies which are synthesized, these antibodies are usually synthesized in response to that of these viral infections, right? Now, these antibodies, all these antibodies are synthesized for these viral infections which are present. So these antibodies, when they're synthesized, they fail to recognize these pathogens as foreign. And they think the follicles are also foreign. So there's a cross-reacting antibodies. So these antibodies, they get misdirected. So these antibodies will go and act on the respiratory tract, but these antibodies will also go and irritate the thyroid follicles. Now, as they irritate the thyroid follicles, they are causing an inflammation of the thyroid follicles. Now, because of inflammation of thyroid follicles, the follicles are going to get irritated, but at the same time, as the follicles are getting inflamed or they are getting irritated, inflammation called ruber-caloid dollar tumor, so there will be a lot of edema that occurs around the follicular status. Now, as there is edema around the follicular status, obviously the thyroid gland is going to enlarge. So you will notice that this patient's thyroid gland, is going to get enlarged, and this enlargement of the thyroid gland is because of the edema in the thyroid gland. It is because of the edema in the thyroid gland, and this edematous thyroid gland is now going to present to you as midline neck fullness. You will see that this entire thyroid gland which is present has become edematous, and that edematous gland is now going to enlarge. And this enlargement of the thyroid gland under the influence of this cross-reacting antibodies, is what we call it as the de Quervain's thyroiditis. Now, because there is all these antibodies, they are going to cause excessive irritation. All these antibodies are present, they are now going to cause excessive irritation of the thyroid follicles. Now, as they cause excessive irritation of the thyroid follicles, this irritation of the thyroid follicles will now start to spill excessive amount of T3 and T4 into the circulation. So because of excessive irritation of the thyroid follicles, these follicles will now start to release more amount of T3 and T4 into the circulation. So hence initially they will result in hyperthyroid status. So this is what the basic story of the de Quervain's thyroiditis is. In de Quervain's thyroiditis, there will be an upper respiratory tract infection resulting in a cross-reacting antibodies. These antibodies will go and irritate the thyroid follicles. Irritation of the thyroid follicles will cause excessive release of T3, T4 initially, hence causing hyperthyroid status. And also because there's a lot of inflammation in the gland, that will cause edema. Edema will cause swelling of the gland, hence the neck swelling. Okay? So how would these patients present to you? In terms of clinical presentation, these are the patients who will present to you with midline neck fullness. These are the patients who are going to present to you with midline neck fullness. I'm not going to tell you it's a midline neck swelling, because swelling will have well-defined border. It's an edematous gland, so hence it is going to become enlarged. So there will be a bulky neck. You'll see in the midline of the neck, it looks, it appears to be swollen, but it does not have a clear margin. So hence there will be a midline neck fullness that is noticed. Along with midline neck fullness, you will notice the patient will complain about pain in the midline of the neck. They will complain in the pain in the midline of the neck. Now, one of the most important pickup point that you would actually see in these patients, that every time the patient swallows, when he is eating, drinking, the gland is going to move upwards. Now, inflamed gland it's already so friable and you're making it to work, you're moving up and down, obviously the component of pain will increase. So patient will tell you that the component of pain increases during swallowing. It is going to increase during swallowing, right? So the presence of midline neck fullness, there'll be pain in the midline of the neck, and that pain increases during swallowing. Along with that, there will be a history of upper respiratory tract infection, which is quite evident that you will see. Because of excessive release of T3, T4, the patient will also have initially presence of signs and symptoms of hyperthyroidism. So initially, patient will have features of hyperthyroidism. Now, this hyperthyroidism is because of cross-reacting antibodies. These are because of the cross-reacting antibodies. Now, I hope everybody knows these cross-reacting antibodies. These antibodies are due to upper respiratory tract infection. These antibodies are because of upper respiratory tract infection, right? Now, if you understand the whole analogy, I can give you a simple way to decode this. Let's say if the upper respiratory tract infection subsides. Let's say if the upper respiratory tract infection subsides, obviously the cross-reacting antibody synthesis will also decrease. If these antibodies are going to decrease, obviously the follicular irritation will decrease. So hence what is going to happen? This will eventually become euthyroid. Okay? So it will eventually become euthyroid. Once the cross-reacting antibodies are going to decrease, there will be no irritation of the thyroid follicles. When there is no irritation, the follicles will regain back to the normal status. It will become euthyroid. Did you do anything to make the patient euthyroid? The answer is no, because you didn't put any effort. Patient become euthyroid by himself or herself. I can say this is a self-limiting condition. I can say this is a self-limiting condition. Bad doctor, beta, what I'll do is after today's lecture, I will compile all the lectures ka jo bhi notes hai of a BLS series. We are going to post it in our group today. You can have an access from there. Okay? So yes, it's a self-limiting condition. So nothing to worry about in such. So how would you evaluate? In terms of investigation, because the patient has presented to us with swelling, I would perform a thyroid function test to see the status. I would also perform an ultrasound to see an enlarged gland. Do I need to do an FNSC, inflamed gland, hyperthyroid status, friable component? All of them goes in favor of not doing an FNSC. So here you don't need to do an FNSC. All that you have to do is a thyroid function test, do an ultrasound, see a uniform or diffuse enlargement of the gland. Once you know it is a D. Quervain thyroiditis, it is a self-limiting condition. So do not do anything. All that you have to do here is to perform or give the best supportive care. You can give a best supportive care. When I say best supportive care, for pain, you can give analgesia. You can give anti-inflammatory. If it is going to be a severe form of inflammation, you can also give steroids. Otherwise, it's usually responds well. The prognosis is good. You don't need to really worry about it. Okay? So it's a self-limiting condition. All that you have to do is give best supportive care. Right? So best things in life works out if you have the belief. One best example is your D. Quervain's thyroiditis. Okay? So this is all in all with respect to subacute or D. Quervain's thyroiditis. The another one that we'll be talking about is going to be our Riedel's thyroiditis. Right? So Riedel's thyroiditis is quite tricky for us to, take across. We'll try to understand this. In Riedel's thyroiditis, Riedel's thyroiditis is an example of a chronic thyroiditis. Is an example of the chronic thyroiditis. It is an example of a chronic thyroiditis. Okay? So let's understand what is the cause behind this, right? The cause of the Riedel's is not purely understood, so we now consider to be as idiopathic, but sometimes it can also be considered as autoimmune in etiology. Whenever we consider that it is an autoimmune in etiology, the antibody which is usually associated with this, The antibody which is usually associated with this is your IgG4 class of antibodies, which is going to be your IgG4 class of antibodies. What are the other conditions which are associated with the IgG4 class of antibodies? You can see the IgG4 class of antibodies are also seen in autoimmune pancreatitis. It is also seen in autoimmune pancreatitis. It is also seen in your retroperitoneal fibrosis, or I can say autoimmune retroperitoneal fibrosis. It can also be seen in autoimmune retroperitoneal fibrosis. So we have your D. Quervain's thyroiditis. Along with D. Quervain's thyroiditis, autoimmune pancreatitis, as well as autoimmune retroperitoneal fibrosis. Yes, if you talk about Ormond's disease, that is an idiopathic retroperitoneal fibrosis. But if you're considering it to be autoimmune, it is your IgG4 class of antibodies. Absolutely correct, Mansoor. It is true, right? Now, in your Hashimoto's thyroiditis, usually if you say what is the pathophysiology, the pathophysiology of the Riedel's thyroiditis, it is an idiopathic auto-fibrosis. The magic word to remember, it is an idiopathic. There is an idiopathic auto-fibrosis. It is an idiopathic auto-fibrosis of follicles with recurrent inflammation of the gland. With recurrent inflammation. There's going to be recurrent inflammation of gland is noticed. The recurrent inflammation of the gland is going to be noticed. So if you observe, you will see the gland which is eventually or initially of this size, right? We'll just try to reconstruct the whole component. The gland which is this in the normal status, you will notice that it is now going to become something like this. And eventually you will notice it will become something like this, right? So let's understand how does a gland which starts its journey from here becomes this, right? So what is the objective here? Again, for the sake of understanding, let's say these are the follicles that we have. These are the follicles that we have, right? In an Riedel's thyroiditis, there's an idiopathic autofibrosis. So few of these follicles, they just die. You know, they are tired with life. They are like, okay, we are done. So hence they call it a day and they collapse, right? It's like one fine day, follicles were sitting, thinking about what's there in future. They found there's nothing much. They didn't find a way, you know, they didn't have a purpose to live. So they said, okay, when there's no purpose, we might as well end. The problem is not the guys who end their life. It is the guys who are left behind. Okay? So all those guys who are left behind, now they have to take care of these follicles which are destroyed. The follicles which are destroyed, they're fine. But whichever follicles are left behind, now they have to compensate. Now they have to compensate for the lost follicles. So these follicles which are left behind, they undergo compensatory hypertrophy. Now as they undergo compensatory hypertrophy, you see the gland is now enlarged. But again, this is a habit. The follicles which are left behind, they also think, okay, this follicle was in love with this follicle was in love with this follicle was in love with this follicle. Now once their lover has died, they say there's no purpose for them to live as well. So they also decide to die. So these follicles which are left behind, they also are going to undergo autofibrosis. Now because these follicles have undergone autofibrosis, whichever follicles were left behind, they will try to compensate. But the problem is, you'll see eventually the whole of the gland is now going to get fibrosed. So entire gland is now going to get fibrosed, and very few follicles which are left behind, they will eventually also give up in this process. You will notice the follicles which are left behind, they are trying to compensate. These are the few follicles which are left behind, and they are trying to, you know, take care of whatever is left behind. But eventually these follicles will also give away, hence resulting in this whole process. Now, if you have understood the whole process, what has happened? You see there is an auto-fibrosis. Now, because of this is normal, this has resulted in auto-fibrosis. There's auto-fibrosis of thyroid follicle. Now, because of auto-fibrosis of thyroid follicle, there is compensatory hypertrophy. There is compensatory hypertrophy. Now, because of compensatory hypertrophy, there is an enlarged thyroid gland. There is an enlarged thyroid gland. This we have understood. Now, because the entire follicles are getting disrupted, what is going to happen? Along with this enlarged thyroid gland, there will be decrease in T3 and T4 production. So, since the beginning, as there is fibrosis of the follicles, in order to keep euthyroid, they are compensating, but eventually they will present to you with hypothyroid status. One more interesting thing, because there's a repeated inflammation that you'll see, there's a lot of periglandular fibrosis that you will see in Riedel thyroiditis also. The extent of the periglandular fibrosis in Riedel thyroiditis is far more extensive when compared to that of Hashimoto's thyroiditis. So in Hashimoto's thyroiditis also, you will see there is a periglandular fibrosis. That periglandular fibrosis is plastering the gland to the surrounding tissue, but the extent of the periglandular fibrosis is far, far more severe in our patient of Riedel thyroiditis when compared to Hashimoto's thyroiditis. When compared to the Hashimoto's thyroiditis. Clear? Okay. Now, because of this, how would a patient present you? So in terms of Riedel thyroiditis, when you look at the presentation, remember again, this is a disorder that you will see more common in females when compared to males. For Riedel thyroiditis, the usual age of presentation is seen in age above 50 years. So is your 50-year-old female presenting with the following symptoms. So what are the symptoms that you're looking at? Number one, you will notice that there will be presence of huge midline neck swelling. There's a huge midline neck swelling that is present. Now this huge midline neck swelling, it is associated with severe pressure symptoms. It is associated with severe pressure symptoms. Such a large gland will exert pressure on the underlying structures. Because of a lot of periglandular fibrosis, it is going to involve the carotid sheath. Hence, it will also have Berry sign positive. You remember, we have already discussed in detail in our previous lecture what is Berry sign positive. It is an impalpable carotid pulse at its normal location. It is not absent carotid pulse. It is an impalpable carotid pulse at its normal location. There is a huge swelling in the midline of the neck. It is associated with severe pressure symptoms. There will be presence of Berry sign. When you examine, on examination, what do you find? It is going to be hard. It is going to be nodular. It is going to be nodular. And remember, the movement with deglutination. The movement with deglutination, I would not say it is absent, but it is definitely restricted. It is definitely restricted because of periglandular fibrosis. So it's a hard nodular movement which is restricted with deglutination because of periglandular fibrosis is noticed in this patient. In fact, if you see all these features, no, we'll discuss tomorrow when you talk about malignancy, all these features that are present, these suggestive of malignancy. In fact, the most common differential diagnosis. The most common differential diagnosis for Riedel thyroiditis, it is your anaplastic. It is your anaplastic carcinoma. It is your anaplastic carcinoma. Clear? One second, I can't see you guys. Okay. It is your anaplastic carcinoma. Right? Now, on this context, what is the investigation that you can perform? So if your patient is presented to you like this, the first investigation, again, it is going to be thyroid function test. The second, it is going to be an ultrasound. Third, to rule out malignancy, we will do an FNSE. In a thyroid function test, we will look at the T3 level, we will look at the T4 level, we will look at the TSH. From the beginning, you will see T3, T4 is going to be less, the compensated TSH will increase, telling you it has been a hypothyroid status. So once you confirm that it is your Riedel thyroiditis on an FNSE as well as an ultrasound, The management, I cannot do much about it. The only thing, first I will start the patient on thyroxine, that is the supplement. And for severe pressure symptoms, we have already discussed it. For severe pressure symptoms, even if it's a Riedel thyroiditis, because there's a lot of periglandular fibrosis, I cannot operate. I will perform Isthmectomy. I'll remove the isthmus of the thyroid gland so that it can regress back to normal. So this is how you are going to tackle your Riedel's thyroiditis, and in a nutshell, this is what we should know about inflammatory thyroid swellings. So I hope you understood the entire lecture. I hope you have gone through all the topics that we have discussed today. We have discussed 3 important topics. We have spoken about number 1, Hashimoto thyroiditis, number 2, Quervain's, and number 3 is your Riedel's thyroiditis. If you have any questions, fire it away, or any suggestions, anything that you want to add, because we are finishing our first season, I would call it as, not chapter, that is going to be our BLS ka component. Okay? True cut biopsy will be better or not to rule out malignancy. But in thyroid, no, we do not go with true cut biopsies because the gland is so vascular that it will bleed extensively. At the same time, we say the minimum biopsy that you should consider in a thyroid gland is always a lobectomy. Okay? So whenever in doubt, we'll talk tomorrow that whenever you're in doubt, no, especially if it is a borderline in an FNSE, we'll go ahead with lobectomy and frozen section, determine on table whether it's benign or malignant, and then move forward. Okay? Rahul, thank you so much for your appreciation. But if you have any questions, any queries, you know where to reach out. You can follow. We have a small group on the Telegram, which we continue to post. It is called as the Surgery Guy. The Surgery Guy is me. It is by my name only. You will find Dr. Sandeep Seeram Reddy. So if you have any questions, any queries, you can post the questions or queries on the Telegram group. The name on the Telegram is also same. The name on the Instagram is also same. You can follow it on there. Add your questions. Feel free to ask any questions, any queries. Let it be personal, professional, anything. I'm there for you. With that, thank you so much for today. We'll resume back tomorrow, same at 9 o'clock. And trust me, tomorrow we'll talk about malignancy, and I will take you to the TNM of the thyroid in a way that you have never learned it before. So stay tuned for tomorrow. I'll see you guys again at 9 o'clock. Signing off. Thank you so much for your time and love and appreciation. I've been getting a lot of messages on my Insta DM as well. Keep continuing, to send all the questions, all the queries. If you find something interesting in Word, take a picture, post it, tag it. We will try to solve that question as well. Thank you so much. Bye. Take care. Have fun. Thank you guys. Thank you, Lakshna. Bye bye. Take care. Signing off.